Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Yasir Abdul-Rahman about sharing care, expanding primary care delivery. Let's get started. Oh, Dr. Dan, good to see you.
Good seeing you, Faisel.
And Dr. Abdul-Rahman, welcome. It's so good to see you. Great to have you on.
Thank you so much for having me. I'm so excited.
Yeah, the conversation with you, we're very excited because, so much changed during COVID, right? There was a lot with residency training and then starting your career during that time. It's not something that we talk about enough. Like what happens when you start your career during a time of chaos, and instead of resisting it, you're somebody who actually, you embraced it and you built something new out of it. So we're really looking forward to having this conversation today.
I feel like this is a full circle moment because during those crazy times in 2020, I was listening to you guys keep primary care going and the conversation going. So it's really nice.
Yeah, I mean, it is and exciting to have you here with us. But I mean, I know you've talked about some of the things that you're working on and some of the things you're interested in, and just realizing that there were the adverse consequences of training in the pandemic, but there are also probably some good things that came out of that too.
Yeah, I think primary care has a reawakening since 2020, right? Healthcare systems start seeing the benefits of us. I remember in residency, we were one of the first residencies to really reach out to patients before the lockdown even got initiated, right? And helped a lot of people avoid emergency room visits and hospital visits. So
I know you're coming in, starting your career at a time when it's expected that in Virginia, about 1 in 3 primary care physicians are over the age of 60. So a number of us are going to be retiring in not too many more years. And so how are you looking at being able to scale what you're doing? What are your thoughts about some options about that?
That question has been answered by so many giants before me. So as I answer it, I'm sitting on their shoulders. So one of the options that I know in our healthcare systems in Virginia, what we're doing is we're implementing shared medical visits, right? Which is a concept that was first really talked about and written in literature in 1970, believe it or not. But really, Mass General up in Massachusetts really started implementing it back in 2000 with their lifestyle medicine team. And Dr. Mirsky is one of the great leaders in that, and he's kind of set the tone. Cleveland Clinic, all these great opportunities, all these organizations have already instilled in their systems shared medical visits, which I think not only will increase access and decrease provider burnout, but it also will give that education that we can't give in a 15-minute appointment. As we kind of talk today, hopefully we will dive into that. But I think that is one of the tools that we could use as primary care doctors to really ramp up our care for our patients.
When I talk with the younger doctors who are just getting into all of, this crazy world, and especially for you all who trained during the time of COVID and you got into practice, during that time, and I hear you speaking about these innovative, I mean, you're taking something that has been studied and all, but to actually implement it, it makes me wonder, are you so innovative because you were forced to be less attached to how things ought to be because, you were thrown into this crazy world. You didn't just, put a shingle up and get started. I mean, you were just thrown into this. It makes me just wonder, did it force you to trust yourself? Like, did you have to trust yourself faster? I mean, I remember it took me a long time to trust myself. I felt like I had to, for so many years, I had to keep proving myself before I could trust myself. I'm so impressed by this,
I mean, I think as you see, like a lot of new grads are innovating, not only as soon as they get into a healthcare system, but direct primary care. I mean, who would have thought direct primary care would have such a stance, in primary care in such a early going? But again, that in itself, people have been doing it for years, but now the younger generation who's saying, I really want my time back with my patients, right? But I think we're all men. I think our teachers taught us to mandate world-class care, right? And as we get into the workforce where we're seeing if a patient is waiting too long, yes, we get a survey and the patient is not happy, but something inside of us says, I got to do better. And I think as we work towards kind of developing what we're going to do with less doctors, how do we work with our NPs and advanced providers? How do we utilize our dietitians, our physical therapists, our referrals? And it's an exciting time.
Well, no, I was interested a little bit in the shared medical appointments you're talking about. I know traditionally they've been done in person, face to face, but I mean, they're sort of, people got used to doing what we're doing right now, having a group meeting when I think, Yasser, I think you and I are maybe 100 miles apart, and then the two of us are 500 miles from Faisel, and yet we're able to schedule a meeting this afternoon. How is that? I mean, you work in a fairly urban area. Well, it's still hard for people to get together all at one place at one time, or if you're in a rural area, the transportation's such a big issue. So what are you thinking about what are you thinking about how to solve that distance problem?
Yeah, I mean, I think for not only are we living in an urban time, but people are busy. They can't be traveling. So I think we use telehealth and these shared medical visits to really bring the team together, the cohort of patients together. But in the rural areas of Virginia, they don't have internet. So the only opportunity for these shared medical visits will be in person. So but we are utilizing the telemedicine technology for that.
I'd love for you to dive a little bit more into what a virtual group visit is, and from what you've seen, what kind of patients would benefit the most from this type of a visit. I remember we worked with, when we worked in geriatrics, we had acupuncture doctors, and I remember an acupuncture doctor doing acupuncture on 5 nicotine dependent patients who were trying to quit smoking. And he put the needles in their ears, if I remember correctly, it was around their ears, and he had 5 or 6 of them lined up and and did it in a room. And it was initially I was kind of, I didn't feel so good about what I was seeing there, but then it made sense. It was convenient for the patients, and the patients were speaking with each other. It almost became like a group therapy for not only the acupuncture experience, but also their struggles with nicotine dependence and different things that they each tried over many people struggle for years or decades with it, especially, you're dealing with the geriatric practice. And I said, oh, we should be doing more of this. I don't know why we're so stuck on this one patient one time. I mean, it's not for everything, but I clearly saw a benefit there. And as I'm hearing you speak here, like, I'd love to, just from your experience, like, what kind of patients would benefit the most from this type of a virtual group visit, and like, what kind of problems have you solved with this?
If you look at all the data, all shared medical visits that have been successfully implemented in healthcare systems, may it be in the private setting or in the big corporate world, they all set the same way. They have 2 portions. Most of them are about an hour long. The cohort should be no more than 10 patients, but on the average, they're about 7. That's on the national data. So the first 30 minutes is more didactics, right? You're talking about information that the doctors keep repeating to this patient every 15 minutes, but not really going in detail. So the first 30 minutes, you could talk about chronic disease, what's the guidelines we use, what lifestyle changes in medicine we can implement. All right, so that's the first 30 minutes. Then The second portion, which is another 30 minutes, this is where the patient gets that one-on-one attention, right? Where everybody's listening, right, to the doctor and the patient one by one, talking about lab review, their medication management, where they were last visit, and how are they doing today, for example, on the blood pressure, right? And I'll walk you through examples later. But this, the second portion, that one-on-one, allows us to use that AMA medical decision making to bill, right? So that 99213, 99214. And that in itself makes it a viable option for primary care to adopt because we're doing a great job at informing the patient, giving them one-on-one patient attention. So the person, as they're listening to Mr. Jones getting that one-on-one, he may get questions answered that he never knew he should be asking. And the doctors are seeing up to 10 patients in an hour, but you're also decreasing burnout because you're seeing 10 patients in 1 hour, right? And then you're getting great outcomes because this cohort, you keep seeing them every month and following up. They become cheerleaders for each other to ensure that they're pushing each other. And we see that in every group visit that I've seen. So it's very important we say this is more shared medical visits, not group visits, because we are really sharing a visit to get better and enhancing our care.
Do you group them by their condition? Do you group them by what their main complaint may be? Like, I just want to understand a little bit.
At the beginning, as people are adopting this, I do recommend they choose a diagnosis for each shared medical visit. So all patients have hypertension, and you focus on hypertension in your first portion of didactics, and as you guys talking about hypertension, but that also will bring in how do you sleep? Do you have sleep apnea? And if you do that, if you talk about two problems and you're treating hypertension, you can get a 99214 from that. So it's very important as we are implementing this, we choose one option. And what we're doing is we are doing hypertension as one, diabetes, GLP management, obesity, dementia, ADHD. And how do you kind of scale that is once you have that cohort and you understand what the cohort is doing and you kind of set this shared medical visits are going to be 4 sessions where I'm going to teach you how I diagnose it, what diet you need, how do you manage your stress and exercise. And once you complete that shared medical visit, then in itself, you have something the primary care doctor can refer to. Like I see Mr. Jones for hypertension, and I'm going to see him in 3 months. But in the meantime, Mr. Jones, complete these shared medical visits as between our visits. So by the next time I see you, we're not just keep refilling, but potentially we'll be starting demedicating you because you fixed the underlying causes.
Oh,
yes.
Now you got tell me more. I need to know more about this because you'll see on my LinkedIn, I got from my mom. She said, good doctors prescribe medicine, but great doctors wean patients off of them.
And I think for us, again, we stand on the shoulders of giants, but if you look at the studies, right, I think health in itself is like a tabletop. You got to balance it. So you really need to have 4 strong sets of legs, right? One would be you got to make sure your stress management is optimized, sleep is optimized, you understand what exercise is, and you got to understand your relationship with food. And people with diet, they say plant-based or keto, it doesn't mean you have to do that every day. Well, keto, you have to do it every day, but plant-based, right? You don't have to do that every day. You can do it 4 times a week and you'll get some benefits rather than trying to keep up and saying tomorrow I'll start this. And again, these are shared medical visits. You could start strengthening those legs. So a stressed patient who's taken medications for hypertension because they're stressed from work starts building some coping mechanisms and reaches out to the therapist. Or, for example, when I did mine on my first during the hypertension, I had one patient that's very, very resistant and denying sleep apnea. Like I'm telling you, it was a fight every time. He knew I was going to say it and I knew he was going to deny it. But I brought it up. And two of the patients in that cohort supported me and said, listen, you have the same symptoms as I do. And once I initiated my CPAP, I lost this much weight, right? So it's really nice. I think once a cohort becomes intertwined and they're seeing each other every month or so, they become coaches, and then you could use them. You could use those people who graduated from one shared medical visit. You could use them as your cheerleader for the upcoming cohort that you'll do.
That is fascinating. I'm really loving this. I mean, I feel like we could use this also for like well child visits. We could use it for just the annual checkups, with flu vaccine season, like just get a bunch of people together and let them talk through all their fears, like colorectal cancer screening, cervical cancer. I mean, I'm so excited about this. Like it's like you have your own little show, and then you have the audience participation, and you're nudging the conversation along and
It's
helping them all
exciting.
receive similar, yeah, because
And
it's
I
great.
think I think like most primary care doctors, once you introduce this, they may give you resistance saying, I don't want to do more. But once they start understanding what you're actually doing and you start seeing the benefits, they will start buying in because burnout is real. And we all talk about burnout and people are retiring because burnout or switching their career. But this is one of the tools that we could use to really give that access that we're begging people to get, but it also, if our colleagues in neurology, endocrinology start seeing how much benefits we're getting, we're less burned out, patients have access, and we're getting reimbursed. There are referrals that people are waiting months for. Those specialists will start doing their own shared medical visits for those hypertension patients that don't need to see cardiology, but they have that appointment, so you could group those, and that could open up a sooner appointment for that patient who had a coronary issue of the past weekend who got discharged.
I'm assuming you have everybody sign a HIPAA release that they understand they're sharing information in a group and they're okay with that. Yeah.
Yeah. So HEPA is signed before they even walk in. They understand some healthcare systems may use AI like a bridge, or there's so many AI note writers these days, but they also, if the doctor wants to implement that, that's a tool. And again, the doctor is not in it by themselves in this. They have a facilitator. This facilitator is either MA or RN within the office who make sure the patient is aware of their visit. We have the front desk before they even get on, check their insurance. Our facilitators are a great help in saying, it's time to see Mr. Jones. You've talked too much to Mr. Johnson, right? But our facilitators is very important in that. So this is the prepping, the shared medical visit is so important, but I think everyone needs to go through the growing pains, because it's, even though if you give them like a PowerPoint with all the information, with every visit, every doctor, there's going to be something we learn.
I hate to admit this, but I just love it when it's easy and we're not dealing with a prevention hesitant patient. But yeah, but it can be exhausting, especially late on a Friday and you're tired, you didn't sleep all the night before, and you've got someone who's being very hesitant on a Mickey Mouse issue, something that, it can be exhausting. It can be so exhausting sometimes to kind of, okay, let's go through, let's use the motivational interviewing. But like throughout the course of the week, I think about like just how much that has become part of my life with just engaging these resistant, prevention hesitant populations of people for different reasons. Maybe super early prevention or just some of the basic lifestyle modification prevention hesitant population. What has your experience been with having, let's say if you have 10 people in an hour, you may like, have you found that maybe you'll have one or two prevention hesitant conversations and then the rest of them kind of learn from And then you're not having to have 10 prevention hesitant population conversations, but you're just having maybe one or two really, really good ones, and then everybody else kind of does a group think, and they learn from that, and they're like, well, I better not ask them that. I can just think about, like, is there a multiplier effect going on here?
I think for us, with like I had two resistant patients, but you have to meet where the patients are. And sometimes they do need to hear conversation with others. And you can start seeing, once you follow up with them, you start saying, you start seeing like, hey, they're getting this. They're getting what I'm trying to throw out. And so I think, again, shared medical visit is a great opportunity for those patients to not only will they get a didactics piece of, hey, maybe I am eating the wrong food. Maybe that's why olive oil is good for me, because when I do the dishes, the olive oil comes off the dish much easier than the other oil that I use. Or, when I'm the sleep apnea patient, I mean, I think that's one of those things that's going to stay with me forever. But I don't want to just hone in on just hypertension. I think with the GLPs, right? This is one of those medicines where potentially we start the patient on and we don't give them an end date. Again, some patients may need them ongoing, but what is your goal weight loss? What do we want here? When are we going to move the stick to get you that BMI where you are healthy, where we could start demedicating you?
Yeah, I'm just fascinated by this. This is just great. What if patients taught each other, that you've seen them, they're teaching each other because now they've known each other, right? They're going through similar, that you couldn't have taught them one-on-one?
I think from a hypertension standpoint, one of the standout conversation was we were having a conversation about what's your blood pressure at home. And the patient was telling me, my blood pressure machine is so wacky. It's just giving me these crazy readings. And the other patient was like, did you change the battery? So it's like that.
We should do residency lectures like this, Dr. Dan. I'm thinking about all different applications. We can use the same thing. They can teach each other,
Yeah.
Yeah.
And the other ones, like for the GLPs on weight loss, I mean that conversation they talk to each other. Basically, you'll have one that just started the GLP, and the other ones who's been on it for a little longer, who's you kind of been honing on, kind of figuring out where they want to be with their weight. And they're like, wait, so the new patient was saying, I'm having constipation and nausea. I just don't know where this is from. And the other patient kind of weighs in. Is like, usually this happens when you change the dosing. Did you change the dosing recently? So our patients are very intelligent in what they're doing. They
People
don't
want to
get a
help each other.
chance. Yeah, they want to help.
Yeah.
Well, and I mean, it's interesting because a lot of times, and probably most of the time, we're prescribing drugs that we don't have any personal experience with. I remember I had been in practice for 5 or 6 years before I had a newborn child at home. And after about 6 months of having a newborn child at home, I realized all the things that the books were telling me to tell new moms were a bunch of hooey. And it was, I think it made it better, but I can see where that would make a difference, especially like the GLP-1s. I mean, people do have problems. I was at an IHI conference one time, and I don't remember, might have been Don Berwick, it might have been somebody else, but they said the problem with the way a regular office visit works is when we're seeing patients every 6 months, as we give them a plan, it's like the pilot coming out of the cockpit of the airplane and saying, here's the manual about how to fly the plane. I'll meet you on the ground. And they take a parachute and jump off, and they leave you to fly the plane and land it somewhere. And that's what we ask patients to do, right? Is we see them in a 10-minute visit, 10 minutes face-to-face time, hand them the prescription, and here, go do this, and then we'll talk again in 6 months. And I like the idea because it gives people more time, right? That they will feel more listened to, and the conversation that's happening is more about the stuff that they're dealing with. So
We're living in such a lonely time. I mean, that must be great for the patient. How do they feel when they connect with each other? I'm sure you're developing friendships and relationships from this.
2 words are meaningful and memorable.
Wow.
Those are the 2 words that kind of resonate for us. And again, the primary care doctor still has the patient under their wing. he or she just set them up with a shared medical visit to enhance their care. So when you're doing these things, as you scale it up, because initially you're going to have seeing your shared medical visit with your own patients. Then you start seeing it within your own clinic. Then once the shared medical provider is ready, they can scale it up to the whole primary care service line.
Yeah, because you're not just scaling access, you're scaling relationships. That's what you're doing.
And expertise. I think when you look at it as primary care doctors, we know a lot and how to treat a lot of things, and especially as we grow in expertise, we may have the same expertise as a referral specialist with some areas. And I think we could give meaningful care, greater access to our patients through our own service line.
So if somebody were listening to us today and they think they're, say, a second year resident and thinking about what they're going to be doing and they're excited about this, or even a medical student, they're excited about this, what do you think would be important for them to learn during their training that would be helpful for them to be able to get started? Because all training programs aren't necessarily going to have this, and there are probably some skills that you're finding more useful than others. So what would your advice be to somebody who says, yeah, this is pretty cool. How do I get ready to do this a year down the line or 2 years down the line?
I mean, I would say learn the stuff we didn't really learn in medical school, which is nutrition and lifestyle medicine. I think you start seeing primary care doctors being diplomats of lifestyle medicine. I think if they could go to a conference or two, I mean, that's going to be setting them up to be very, very successful when they start and have that memorable experience when they're given the didactics and talking one-on-one with the patients. They'll be not only talking to that patient, but they're also signaling to the rest of the group.
Wow. Thank you so much for taking the time to join us today. This has been a great conversation. I'm so excited from this conversation. I mean, I want to do this too. I want to do this too. I think what you're showing over here, I mean, the group visits solve so many problems about where primary care fails. I mean, primary care doesn't fail because we don't care. It's always because we didn't have enough time. We don't have time for the repetition. People need repetition, right? And we don't have time to build like that community, that group think. And this solves all those problems.
And the reimbursement, again, I think with the reimbursement piece is very important. To get this reimbursements, according to AMA, we have to make sure it's a MD, DO, NP, or PA. No discreditation to our dietitians and health coaches, which is very vital to the team. But to get that billing component, we have to make sure we kind of emphasize that DO, MD, NP, and PA those are the providers that should kind of handle and be managing shared medical visits.
Yeah, I mean, this is another example of you're showing us like what so many before have, that the future of primary care is not going to come from some policy change or something like that. It's going to come from somebody like you explaining beautifully how we can do this. I mean, these are ideas before, but you've actually implemented it. And that's how it's going to happen. Seriously, this is how it happens.
And again, we have to lean on each other too, right? There's not just one healthcare system doing it. We have to reach out and do this as a primary care family, because the growing pains sometimes can be disheartening, but if you're guided and if you're patient enough, got a good facilitator, manager, it's so doable. And there's so many papers out there. And again, just like I started, a lot of credit now goes to Dr. Mirsky and Mass General. Lifestyle medicine, he's like the shared medical guru in my eyes, because every time I listen to him or read the publications, he's kind of set it up, and he has shared a lot of the didactics pieces too. So it's even easier for us to start shared medical visits, because the didactics piece, it's out there, and the association like American Heart Association, Diabetic Association, they already put these great diagrams that you could use for your patients they're already colored, and he's got to explain what they're looking at, and it will resonate with them.
I love it. I love this. This is a great conversation. Thanks again so much. And thanks for reminding us, primary care is really, it's the only specialty where the relationship is a treatment. Thanks again.
What are your thoughts on sharing care, expanding primary care delivery? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.